automatically people coming in. Might just give it a minute or two for more people to pop in. Okay, everyone, we might get started. Welcome, everyone, to the AAAPC first webinar of the year, presented through the Early and Mid-Career Academic Research Subcommittee. Tonight, we'll be hearing from Associate Professor Darshini Ayton, who will be presenting on connecting research with the real-world consumer engagement and co-design. Can I just have the next slide, please, Emma? Just before we begin, the Australasian Association for Academic Primary Care acknowledges the Aboriginal and Torres Strait Islander peoples as First Peoples of the Australia and Maori as Tangata, Wānua and Treaty of Waitangi partners in Aotearoa, New Zealand. Thank you, Emma. So I'm Professor Leah East. I'm a Professor of Nursing at the University of Southern Queensland and your host for this evening. And I would like just to begin to introduce you to Associate Professor Darshini Ayton. So Associate Professor Darshini Ayton has a strong track record in health and social care research and methodological approaches, including qualitative research, consumer and community involvement, clinical registries, randomized control trials, and implementation science. Having only been awarded her PhD 10 years ago, she is now the Deputy Head of the Health and Social Care Unit at Monash University and an NHMRC Emerging Leader Fellow. Great achievement. Darsh is leading the Health and Social Care Unit, Ageing and Health Services research work and is a Chief Investigator on an NHMRC Centre of Research Excellence and Primary Investigator on a Medical Research Future Fund and National Centre for Healthy Ageing Funding and multiple industry health service and aged care provider funding. Her program of research links acute care to community and residential aged care and encompasses dementia prevention, innovative diagnostics for dementia, and sector-spanning models of care to improve quality of care and quality of life. Welcome, Tash. That was quite quite a wonderful introduction. And over to you for your presentation, please.
Thank you so much, and thank you so much for having me this evening. So I will share my slides. Hang on. Here we go. Oh, can you see that all right? Perfect. Yes, very thrilled to be here chatting to you today about a topic that is close to my heart, which is all things consumer engagement and co-design. I too would like to pay my respects to the traditional custodians of the lands on which I'm zooming in from, which is the Wurundjeri people of the Kulin Nation, and I pay my respects to their elders past and present. And so I just wanted to begin by saying I wear many hats, and I know that introduction was quite long. Thank you for reading that out, Leah. But I am a researcher, but I am also a consumer of health services. I get cared for in general practice, but also under multiple specialists. And so I've lived experience of navigating the health system. You will need to bear with me tonight because I have been in and out of general practice all of this week because I have atypical pneumonia, which I'm recovering from. So if I do cough a little bit, that is why, but hopefully we will be okay this evening. I wanted to start this presentation just with a quote by one of the leaders in consumer and community involvement, although it's called patient and public involvement in the UK, and also qualitative research and health services research more broadly, Tricia Greenhalgh, who started one of her papers in 2019 with this quote, borrowing from Jane Austen's Pride and Prejudice a little bit. It is a truth universally acknowledged by policymakers, researchers, and research funding bodies that patients and the public should be involved in research, though there are different perspectives on what such involvement should look like. And I think that is the crux of it, is that we are now grappling with how do we do this? How do we do patient and public involvement or consumer and community involvement well, which is what we call it in Australia. What does it look like for different projects, for different communities, for different grant opportunities, for practice? And so we really need to think about that. And I'm hoping that by going through this presentation, you'll get an understanding how in your real worlds, you'll be able to hopefully engage with this a little bit more in your work. But to begin with, I thought it was helpful just to go back to understand where does this all get positioned. And so there are many different models of how we work and how we do things. And predominantly in health services and in Western culture, we have this medical model where I guess a catch cry you could say, or one of the many catch cries, is everything done is to us and without us. So if you're thinking about this from the patient perspective or the consumer perspective, it's very much recognizing that doctors and health professionals and clinicians are the experts, and we come to consult with them, and that they are the experts in terms of then the care that is delivered to us. Then we have the charity model, and I was talking about this with colleagues today about the not-for-profit sector and how that was established and kind of what they were hoping to achieve in terms of social justice and all of those types of things. But again, there's a little bit of paternalistic approaches that might happen with that model, where everything done is done for us without us. So how do we know what is something that someone may want or the communities are wanting, or are we just saying this is what is best for you? Then we have the two bottom models, which is where we are striving to be in this space, where we have the social model, advocacy, co-design, co-production, asset-based approaches, where nothing for us without us. And we really start to see this catch cry happening in the space of HIV advocacy, is where we started here at first, but also in the disability sector, and it's slowly moving in to what we see in health and medical research. And then we have the alongside a model, which is everything done is done and led by us. And so this is very much a consumer-led or a patient-led or a community-led approach to the work that is being undertaken. But some key terms, and I guess a thing to note is people use a lot of these terms quite interchangeably. And when we talk about involvement, sometimes we say engagement, sometimes we say participation. But when we talk about consumer and community involvement, what we mean by involvement in that context is that community members are involved in the research process. So they're part of the research team. When we think about this in terms of healthcare improvement, for example, involvement might be having community members or patients part of a team that are looking at how care is delivered. Whereas participation is when community members are research participants. So we're collecting data from them. They might be doing surveys for us or being our interview participants or focus group participants, but we are collecting data from them. They're not part of the research team in the same way as involvement. And engagement typically meant was a way of us sharing our findings and our research with the community, and it was more public kind of one-way discourse. However, people are now using consumer engagement to mean involvement, just to make things a little bit confusing. And co-design is a participatory approach that has a lot of rigor and research behind it. But again, sometimes we use co-design and consumer and community involvement interchangeably, thinking that they might be the same thing. And I would like to say that co-design can be used in consumer and community involvement, but it doesn't have to just be used in consumer and community involvement. And it is a qualitative approach to doing work as well. So just being conscious of that, and I'll hopefully give you some examples to drive that home today. Well, I will be. You'll have to listen to it whether you want it or not. So I guess just to illustrate a little bit more the difference between participation and involvement. So participation, you have your community members or your patients or the group that you are working with as your research participants. They are doing data collection. They're the participants of your data collection. As I said, you need ethics for this before you start. They're not involved necessarily in your data interpretation unless you're doing member checking, if you're doing qualitative research. And they may be acknowledged in publications or conferences, but usually, it might be a once-off data collection. You might have hundreds and thousands of research participants. But involvement, your community members, your consumers are part of the research team. They might be an advisory group. They might be a paid team member. They're advising, they're consulting, they're guiding the process of research, the ideas behind research, the outcomes that you're trying to achieve. You're not collecting personal information from them. And so ethics is not required because they are consulting with you in the same way maybe a statistician might consult with you. They might be involved in data collection, and you'll see some examples coming up where we did co-data collection with our consumer members, and also they were involved in data analysis and interpretation. It is increasingly being recognized that consumers in this involvement space can be authors, they can co-present in conferences or present independently, and very much involved in that dissemination and translation piece. And there might be an ongoing relationship or partnership with the members of your consumer team, whether that be in an advisory group or whether that's formally as a paid staff member. The IAP2 spectrum of public participation is a really helpful resource because, as I said before, in your world, in the projects you are doing, you may need to choose what level of involvement that you can engage with. And it's not to say one is better than the other. It depends on what it is that you are trying to achieve and what it is you are hoping to engage with. And so, for example, at the level 1 or the lower level, we've got, I shouldn't say lower because I don't want to make it too hierarchical, but inform is very much where as researchers or health professionals or the experts, we are informing out to community members. So you can see the big kind of bubble and then smaller bubbles, and it's a one-way direction. As you move up and we look at, say, the third step of involve, you can see that the circles start to become a little bit closer in size, and you are working with your community members to make sure that their concerns and aspirations are being what is addressed in the work that you are doing. And you can see it's a two-way interaction. And then if you have collaborate, you're partnering with the consumers and the community members in all aspects of that decision making in that project. And so that's where you can see that they're moving towards being more part of your team. And then empower is that the last, I guess, stage or level where decision making is in the hands of the public. They are prioritizing what is done, how it's being done, and everything to do with it. So something to keep in mind, you may need to start at one level, and then as your project matures, you might then move to different levels, or you might move back and forwards depending on that cycle and what is resources you have, which we'll talk about in a moment, which is right now. So at the start of 2024, I don't know if you started to see all those memes about what was in and what was out for 2024. This is my way of kind of trying to do that, but leveraging off the MRFF put out new principles for consumer and community involvement for their grant schemes. And so kind of summarizing that in a hopefully more interesting way. What is out is tokenistic engagement. What is in is engagement across all stages of a research project. So what we're wanting to see is that you are engaging or involving consumers at the start, to design, to identify, throughout, and then at the end. And often we see it only maybe at the start or at the end, but how are you demonstrating involvement across all stages? We also want to see it in all types of research. So it can be maybe an assumption is made that it's easier in public health and clinical medicine to include consumers. We might have access to patient groups a little bit more, but how do we ensure that involvement is also happening in basic science? And this has been something that I've been doing a lot this year when we've been doing projects in diagnostics for dementia, which are very much about blood biomarkers and MRI imaging and cognitive assessments. How do we make sure that we've got the consumer voice right from the start, and working with laboratory researchers to incorporate and hear the consumer voice? We also want to ensure broad diversity and equity. So what we do tend to see is that we get consumers putting their hands up to participate in advisory committees who may have had a history of being in health. They might be retired, they're generally very well educated, also might be more Anglo-Saxon. And so how do we make sure that we have representation and broad diversity and equity? And that's a whole nother talk, but one of the things is really to think about the ways that we ask for engagement and involvement, and how do we put our EOIs out? How do we go to community? How do we gain trust and build rapport with community members? But this all takes time. And it's not something where a grant call comes out and in 6 weeks' time, you're submitting a grant application and you're trying to find a consumer or two to chuck on there. It's about having that relationship and those connections well before these grants are due, fostering them over time, doing smaller projects and building up, and really making sure that what your consumers and community members are telling you is about being integrated into the research program that you are trying to lead. And that's been one of the most transformative elements for me, is our consumer group for one of our projects has totally changed the way that we are doing that project, and have given us ideas for grant applications that we have now since put in, which we wouldn't have thought of without them. Sorry. So that's just a little snapshot into the consumer involvement part, but there's heaps of resources out there if you want to have a Google, and both the MRFF and the NHMRC have resources on this, and I'll show you a short course in a moment at the end. But I wanted to talk about co-design and what does co-design look like, and some different examples of co-design. So if I was to summarize, looking at all the different approaches of co-design, these are the typical steps. So the first step is, how do we engage with the people that we are co-designing with? And I should say that co-design is a term that's used quite loosely, and I guess sometimes inappropriately. You don't have to always do co-design, but if you are doing co-design, it is really about, well, who's around the room? What is it that you're trying to create? Building those relationships, understanding what you're trying to solve, and then creating something together. So it's not about having something already created and then getting someone to say, yes, it meets their needs. It's about doing that creative process together, workshopping, doing activities together to identify what that needs to do, and then testing whatever that might be, learning from it, iterating together, and then implementing it in the long term. So they're your typical co-design steps. When I first started doing co-design, I was like, this is really loosey-goosey. And I really wanted some structure around it. And I actually went outside of, I guess, the academic world, which may be right or wrong, but the double diamond approach is kind of what's out there in the consulting world. But it helped to, in my mind, consolidate the process. And so the double diamond is really a framework for innovation, which tried to capture how designers think. And so that's not necessarily specific to health and medical research. It's about how do people do this co-design out there in the real world. And this approach is really great if you're trying to create a product. So it incorporates design principles like creativity and having people at the center, and all of these good buzzwords that we look for. But this is kind of the process. If you can see these two diamonds, where you go through a process of discovery, a process of defining, a process of developing, and a process of delivering. And there's a problem definition that kind of happens in the middle. And there's lots of different activities that can happen in each of these different phases. So the example I thought I'd tell you about was one that I was involved with for prostate cancer called the Bro Support Project. And this paper has been published, and so you can have a read of it if you're interested. But I wanted to show you our double diamond process. So basically what we wanted to do was we wanted to build, well, it wasn't our idea, I should say. This came from consumers, a registry, health professionals. Lots of voices were in the identification of what they thought a good product would be. But it was to be an online portal for men who'd been diagnosed with prostate cancer to provide information about services, resources, and all of those types of things. And it was going to be called Bro Support. And so as part of the first diamond of planning and developing, we had focus groups and workshops. And that's the diamond I'm going to focus in on, because that was where I was involved. The IT build and the pilot and evaluation came later. But here are some examples, I guess, of the types of activities that were happening. And you can see there was lots of iterations and lots of different conversations and touch points that were happening throughout this. So there was pre-workshop activities, and we had about 30 men who had prostate cancer who engaged, and this was all during COVID, mind you. And so we did things like trying to understand. You remember that was like step 2 of a typical co-design process. Understand what the journey was like. What was the problems that men faced? What were some of their priority issues to be addressed? And so we did a very kind of creative activities, a river of life and problem trees. And they're kind of more a little bit arts-based. And then we went through mind mapping out barriers and enablers to accessing support, developing up a list of resources, and that was done through a survey that was post-workshop. And then we also had discussion groups and voting. We developed up a recommendation table. We prototyped a little bit of what the portal could look like and presented the data, and people reviewed it and provided feedback on that. And then we finalized some of that key messaging, and then it got sent off to IT to do the build. But this was like the creative process. So you can see it wasn't a kind of flash in the pan kind of one-off conversation. Took a long time. I think this part took us almost 6 or 8 months of like regular contact. And this is just a snapshot from one of our workshops where we had all been online, and we developed some great rapport with these men. And some of they're not pictured here actually, but for some of these activities, we had 3 men with lived experience of prostate cancer who co-facilitated each of these workshops or points in the workshop, because I'm not a man and I don't have prostate cancer. And so having someone present their river of life and present their problem tree and have asked those questions of men made the whole process, I think, a safer place, and one that people could resonate with much more than a Sri Lankan female who was at the time under 40, trying to do that. So that's the double diamond approach. The next one is experience-based co-design, which is also an incredible approach and has particular steps. And if you think about, well, what I would say about experience-based co-design is it's really great for health services or community services or social services in terms of designing the care experience. And so if we have complaining at one end, experience-based co-design is capturing those voices to inform what that care experience should be like. It is a participatory research approach. As I said, it's about designing the experiences, not the processes. And it's really about trying to understand, how do people feel? This one is a real feelings approach to co-design. How do people feel in the service? How do they want to feel? How will they use it? How does it fit into their kind of context in life? And as part of this process, we need to identify what the key touch points of that care experience is. Where were those care encounters, places where patients came in contact with that service? And then what could we do to change what that care experience was? And you need key stakeholders. So you need both patients as the care receivers, but also those involved in care delivery as part of this process, but the patients are at the center of it. And it's a process that takes typically about 12 months, because you set up the project, and the first step is actually, well, usually, although I've done it the opposite way, but usually you gather staff experiences. And so that might be through interviews, focus groups, observations, and then you gather patient and caregiver experiences. And they do say in the guides, and there's some really useful guides out there, that you should film these. I've never had the budget to do the filming, nor have I had the patient group who have said they'd want to be filmed. So usually we do interviews and create patient vignettes or patient storyboards from that interview. And I've actually usually talked to about 20 patients for this. And then we bring the staff and the patients and the caregivers together, and we present some of those vignettes, or in this case, films, and that is a starting point for the discussion around what needs to change or what that needs to look like. And then in the pure form, you're meant to have co-design groups that break off into smaller groups around identified priorities, and they work to develop those up and bring them back. I haven't done that. I usually just have the same group work on the same project all the way throughout, and then you have a celebration and review event. My work hasn't been published in this space yet, so I'm giving you different examples, and I was trying to find a general practice example. So this one was about improving patient experience for people prescribed medicines with a risk of dependence or withdrawal. And so they had 5 GP practices in Southeast England, and they filmed or audio recorded their interviews with patients, and they were exploring experiences of care, of being prescribed medication, medication management, and the process of deprescription. And then they also interviewed healthcare professionals on their experiences of providing that care. And they edited, which I thought was interesting, the interview footage to a 30-minute film, but then they divided that into phases of the patient journey. So I'm assuming they didn't play 30 minutes in one go, but they played it at key points. And then they participated in those feedback events. And then from there, 3 co-design workshops, and people voted on the priorities that they needed to take to those co-design workshops. And then they had an evaluation event. But these were the priority areas. So they said they needed improved information and communication, and that was around having easy to read and access information, a mini review. I'm not going to go through all of these. You guys can read the paper, but then the other one was continuity of care and the importance of seeing the same healthcare professional, which I'm sure all of you will agree is incredibly important. And then alternatives to medication and alternative ways to manage symptoms was the other priority area. So they worked on those different areas as part of this process. So this one, I don't know if you've seen this or done this or been a participant. Conferences are starting to do this a little bit more, which I find fascinating. And so the World Cafe methodology is another co-design process. And it has 7 design principles. But the one that I want to draw your attention to is this is about creating a cafe-like environment and creating a hospitable place so that people almost don't realize, I guess, that they're being part of a co-design activity. So you will often have food, you will often have kind of tablecloths and things for people to be doing and activities. And this is a really great way of connecting with people from diverse backgrounds because it's not your normal conversation or discussion. You typically will have smaller groups where they might rotate across different tables. In the example you're about to see, we have the facilitators rotate because it was in aged care. But it is about listening together, gathering insights, sharing collective discussions, and then creating something from that. So the work that we are doing at the moment is to co-design dementia education for residents and families in residential aged care. And so these are photos. I've got permission to use all of these photos, but there were 3 stations. And so we had residents who were living with dementia, residents who weren't living with dementia. So well, they weren't given a formal diagnosis of dementia. And then we also had family members. And you can see they had pipe cleaners, they had snacks there, they had resources. And we really wanted to understand, well, what was the content of dementia education that you would need? And it's things like we would gather quotes from them, like, how can we talk to them, residents with dementia? Do we speak to them in the same way as everyone else? I don't know. So you'd capture questions through the conversation that was happening at the table. And each table really only goes for about 9 minutes, 10 minutes. You can encourage people to draw on the tablecloths and write, and the facilitator will talk about one particular topic at that table and then rotate throughout. And so we have got some now great ideas around what the content of this dementia education needs to look like, how it needs to be delivered, who it needs to be for. And so we're in the process of designing that, but we ran 2 sessions where there was 3 tables and each table had a different topic that they were addressing. This is another example that has been published. If you wanted an example, you could read up a little bit more. And this was learning to deliver LGBT plus aged care and documenting best practices in professional and vocational education through the World Cafe method. But again, it's thinking about, and usually when you're doing ethics or you're doing your research proposal, you will create a table like this to try and unpack what are you going to do for each of your cafe programs and encounters, what are the pre-cafe activities that you might need to do. But you can see here, for example, session 1, they were asking questions around, well, what does inclusive care mean for you? And what have been your experiences in receiving healthcare in relation to sexual and gender identities? And so they had tailor designed tablecloths on each of the table. People could write on them. There were flip charts. They were sharing and discussing. People were getting recorded, their responses, post-it notes were being used. So you can see there's a lot that can be happening in this space. And it can be overwhelming, I think, as a facilitator if you're doing this for the first time. So my advice to you is if you're doing particularly the World Cafe or even experience-based co-design, have someone who might have done it before, but you definitely need multiple facilitators or people who are doing this with you. This is not a one-person activity. There's more there. I do want to leave space for questions at the end. So once I started to get a little bit more comfortable with co-design, you start to realize, if you go back to that kind of first slide where I kind of went through the main steps, you can create your own method. It doesn't have to be one that is existing. And so mix it up. This was a co-design project I did to create a volunteer project for a volunteer program for older adults with cognitive impairment that went between the hospital and the older person's home when they got discharged from hospital. And so this is where, when you're working with communities, sometimes you want to adopt the language that they use. So I was working with a social service organisation, BaptCare, and they kept talking to me about this elements approach, which if you Google in the literature does not exist. But what they were basically saying is, what are the elements of the programs that already exist in the volunteer space, and how can we bring that together to design something new? So how do we deconstruct something to reconstruct something for the purposes that we want? And I was like, this is an interesting idea. And so we took at the Volunteer Dementia and Delirium Care Program, which was kind of loosely based on the HELP program that is in the US, and then 2 BAPT care programs, My Care, which is about a support service for people living with mental illness, and Home Start, which is a visiting service, because we knew there was a visiting component to the program we were wanting to develop. And we cut up their program logics and the key elements of their programs, and basically asked our participants on butcher's paper to sort them into piles of include, exclude, and maybe, and to also write notes against why. And we had these workshops where we had geriatricians, nurses, volunteer coordinators, consumers, people from BAPT Care, people from 3 different health services, all in the one room, chatting together. And we made sure we had mixed up people across the room as well, so that they could talk to each other. And they developed up this program, which is, this is the support we provide to people in the hospital. And then this is what we do when they come into, when they're discharged and they're going home. And so that's what the program was going to look like. All well and good, but then we also need to work out, how do we implement this? And so we co-designed, what does this implementation need to look like? And so the implementation plans of those existing programs were presented, and we unpacked, well, what were these strategies and the activities that we thought needed to be carried over or created from scratch for our new program. And this is very loose, like kind of template that we were using to fill it out. But some of the activities, who's responsible, what were some of the impacts, and how are we going to evaluate whether or not that was happening? And it was way more complicated than this. This is just a tiny little insight into that whole process. So that's an example of one that I made up from scratch. But then this is another one, a generative co-design framework for healthcare innovation. And what I really like, and I think this is a really useful diagram for grant applications, is this. And so being able to say, hey, this is the pre-design work that's happening, and we might have already done this part. And then this is the co-design work that we're going to do. So how are we going to frame the issue, incorporate lived experience, what must change, what's the vision for the work that we need to be doing together, how do we generate that design, how do we create a future state or an artifact of creation, how do we share those ideas, and then what's the post-design process. But I really like this. And we've adopted this approach in work we're doing in one of our hospitals to improve nurse retention for emergency nurses, and we're kind of following this process. So that is kind of a whirlwind through a little bit of co-design, but I really just wanted to kind of say, you don't have to do co-design. You can work with consumer groups, you can work with your community members, you can do qualitative research to do problem identification and solution generation, and not necessarily have it as co-design. And so if you kind of want to learn a little bit more about the ins and outs, we are running a short course. I just thought I better plug that at some point. and our next offering is in August, but we do go through when would you be doing co-design, when would you not be doing co-design, what are some other engagement methods that you might want to be looking at, because I know that was a lot to cover in a short amount of time. So I just thought I'd leave you with a picture of my dog, who has stayed very quiet actually throughout this presentation. And thank you for your time, and happy to take any questions.
Thank you, Darshini. That was a fantastic presentation. And just for the audience, please note you can pop any questions in the Q&A chat box that is open. I've just got a couple of comments and some questions to start with, Darshini. And I really just wanted to highlight the importance of language and what you said at the start, how language can, it's used, it can be used ambiguously and interchangeably, but really change the meaning of it. So I really appreciated that. And I really appreciated the visual representation on the IAP2 spectrum. I thought that was great. And this is probably related to your workshop. One of my questions was, do you have strategies that you could share on how you actually reach out to key stakeholders and consumers?
Yeah, so I think one of the first things to do is to take a step and go, who are my key stakeholders? And to actually map that out. Who are my key consumers? And then from there, really work to identify, how do I work with them? Like, what's the best and the most respectful way of engaging? And that can take a lot of time. So, I do quite a lot of work in the aged care space. I have quite a few aged care organizations that I connect with. And when I'm doing co-design, or even consumer involvement or community involvement with our aged care partners, it has come from doing things and working with them way before that. So going in and running workshops on dementia with them, giving back to that community in a way, helping them to connect with me, and then from there saying, hey, there's an opportunity to engage in this way. So quite a lot of it is actually going into the community or going into the places where I know my consumers are going to be. And then even from there, so we have a consumer advisory group that has 9 people on it, and we meet fairly regularly, and 4 of them are living with dementia. And it can be very easy to say, oh, we're just going to connect when we have our formal meetings. But I actually, and my centre manager, we call, we text, we follow up, we ask how the dog is going. And from there, they introduce us to more members that they know. And it kind of snowballs from there. So much of it is about that relational element to the work that we do. And so it is finding out, where are the people and how do you go there, and not necessarily expecting them to come to you in the hospital, or you in the health service, or you in the university, which can be really hard.
Absolutely. Absolutely. I can relate to that. Thank you for that. I've just had a question pop up in the chat. Are you able to talk about including health professionals and consumers together in the co-design process to make sure that what is designed is actually meeting all stakeholders' needs and all limitations?
Yeah. So what I didn't mention with the Bro support paper, so worth reading that, is we also ran focus groups with health professionals separately. And we started to understand from their perspective what it was that they thought was going to be important from the portal, what they thought were some of the key challenges their patients were facing. What was fascinating, absolutely fascinating, is one of the questions that we were asking was, do men want to see how they're benchmarked with other men who have prostate cancer at a similar disease state and at a similar age, right? And all of the health professionals said, no, we are not doing that. There are too many risks associated with that. We are not going to, we do not endorse that on the portal. The majority of the men said that would be an incredibly valuable thing for them to know, am I going the same? Am I doing better? Am I doing worse? If I'm doing worse, who do I talk to about that? And how do I engage to have more conversations about that? But they felt it would be really validating. And so then we had to bring the two groups together to have that conversation so they could hear from each other about the complexities and the whys of that rationale. And so in the end, it was included. It went forward as being part of the IT build, that there would be some level with caveats that the health professionals would then feel a little bit more comfortable with, but that there would be a way of saying how people were tracking.
Wonderful. That actually probably leads into this question. How do you actually engage those who may be considered vulnerable, such as people with dementia, and actually manage the ethics around that?
So I used to think that ethics would say no to anything I did with people or research that involved people who are living with dementia, but ethics have been really useful. I've called them many times to gain their advice on how to engage. And one of the things which has been super strong is having our consumers who have dementia as part of our team has meant that they have looked through all of our participant information forms and provided advice as to what they understood, what they didn't understand, what they found helpful. On their advice, we've created smaller fact sheets about the different tests that people might be going through for dementia. We're creating videos. You know, they gave us all of these ways to help us explain what our study would be for people that we were then going to be recruiting who were going through the dementia diagnosis process. So from that perspective, I would say it has been really amazing. However, not everyone on our research team has found this easy to do, because we have meetings that go for an hour and a half. And I might ask a question of our consumer advisory group, and it might take them 30 minutes to get to the point where we go, oh, that you've answered our question. And it's very easy to say that was 30 minutes of meandering conversation, but it's part of the process. And part of doing this work is, particularly for vulnerable groups, it is the one time they feel they have the opportunity to be heard and to advocate on behalf of their communities. And so sometimes there are times that can come across quite strongly. And as researchers and health professionals, how do we hold space for that and not feel impatient with it? We do train our consumer advisors, but we also train our researchers. And it's been a great learning process. And I have now had my laboratory scientist colleagues say how much they appreciate the insights that they have learned. For example, having to do a fasting blood test is not a feasible option for people living with dementia. It's not a feasible option also because they have other health conditions which require them to take medication in the morning that requires them to eat. How do they navigate that? These are the questions that they then ask the laboratory scientists, and the laboratory scientists say, oh, we'd never considered that part. So, it's that, I don't know if that answered your question, but it's hard, but ethics have been fine with it. I think when people have advanced dementia, then it becomes more hard, and we have processes of checking in that people are still comfortable and able to participate at every step. Ethics have been fine with that.
That's great. Really highlights that reflective practice approach, doesn't it? And that partnership approach. There's two questions here. So where you have researchers who are also consumers, how do you use that lived experience to inform your work without taking away from the different perspectives that other people will have? And two,
yeah.
What steps would you recommend taking to minimize the potential harms of asking consumers to share what they may have been difficult or traumatic experiences for them?
I might start with the second one first. So when we set up our advisory groups, we generally, on advice, often with our health professional colleagues, will say, when is a good time frame. So we will never recruit a consumer who is newly diagnosed, for example. It needs to have had enough distance that they have, they're feeling comfortable in the space that they are a consumer. Consumer and community involvement will always attract people who will have a lot to say, because either they have loved the system or they have hated the system. And it's really important in your recruitment and EOI processes to really try and unpack that, so you know that you have people that you are engaging with who can give you the information honestly, but aren't in a place of hurt and are using that almost as a support service, right? And when you have multiple consumers in your group, you want to make sure that they're not traumatizing each other. And so the ways of creating that safe space and making sure people are in a space that are ready for that. And so there've been quite a few times where we've had to debrief with our consumers if something tricky has come back. You have to be prepared to ring, 12 people straight after a meeting to have that conversation, but also to really make sure you're recruiting and supporting your consumers and they understand their role very much as this isn't necessarily just about them. This is about the community they're representing and how do we do this better. They can draw on their lived experience, but in some instances we've said, do not share your personal stories in this space. We can create another space for that, but we want your ideas because we don't want to necessarily traumatize or create sadness, I guess, where we may not have the space to hold that. Sorry, what was the first part of the question?
So the first part was where you have researchers who are also consumers, how do you use that lived experience to inform your work without taking away the different perspectives that others will have?
So I have sat as a consumer on committees. I have sat as a consumer on research projects, but I will always come with the knowledge that I know a lot about the research process, and I do not like being the only consumer then in that committee, because what I bring to the table isn't a pure consumer lens. And I very much recognize that I have a very high level of health literacy because of my research background. And so even my care experiences aren't typical because I'm able to advocate for myself in ways that others may not have been able to, because I know how to navigate this healthcare system. And so often I'm there as a representative because I might have the track record that might help with the grant, but we will always write into the grant that I will then be supporting an advisory group of 10 to 15 consumers who do not have a health services research background. And we often will try and have, as AIs or as co-CIs, other consumers with lived experience. But I think the value that you can have with researchers and health professionals who have lived experience is that they can sometimes articulate some of the things because they know the system, and then how to ask some of those questions to bring some of the other consumers along on that journey.
Thank you. And one more question. Do you have any examples of frameworks or curricula for training consumers about research? It's a great question.
It's a really good question. And so interesting, the Health Issues Centre just got defunded. Actually, today was the last day that their resources were available. And they had like extensive consumer training. I don't know if their website is still up, but worth just doing a quick Google and seeing if you can download anything off their website, because they had extensive consumer training. Monash Partners and I helped set up their consumer training, but that was more geared towards researchers and health professionals. But I always create consumer training specific to the project. Like, what do my consumers need to know? And some of the things that I take people through would be, okay, depending on the project, what are we going to be asking you? So if I know I'm going to be asking our consumers to review a PICF, I need to tell them about the ethics process. I need to tell them about what PICFs are, what kind of feedback we're looking for. I need to orient them sometimes to what is a clinical trial. How do clinical trials work? What's the clinical trial environment in Australia? Where do we sit in that process? And so they're the types of things, depending on what we're doing, that I will train consumers in. But usually it is about, what is your role in this project? Who are the research team? What is it that we're trying to achieve? What is research? What is our ask of you? And having really clear expectations. We have usually very strong terms of references and resources. But if you have my email address, feel free to email me, because I'm happy to share some of the resources that we did develop up for our consumer group, who are people living with dementia. So you can kind of get an idea of some of the things that we've done in that space.
Great, thank you so much. We've got a couple more minutes if there's any other questions. I've just got probably one more question, Dashini, and it was about your comment regarding patient storyboards. And I was just wondering if you could tell your audience what a patient storyboard may look like.
Yeah, so we do that in a few different ways. I have become a big fan of Canva. I don't know if any of you guys use Canva at all, but it's a really great method of kind of making graphic design. And so then we create kind of what the patient story with key quotes throughout that process. So we might have a picture from where does it start to where, the different kind of components throughout. With the River of Life, we've done that on a program called Mural. And so we do sticky notes with images of a river that patients have chosen to illustrate what their journey with dementia has been. And so that became a storyboard as well, with key colors illustrating where boulders were or barriers were, and where the enablers were, and who were the health professionals. And so they then become talking points. And so we present them to like Dementia Australia, to other researchers, for people to see that. But there are now even online platforms where there's a storyboard feature that people can write their stories in, as like almost like an online discussion forum. So there's multiple ways of doing patient storyboards, but much cheaper than doing a film and editing it.
Yeah, thank you so much. It actually sounds like lovely work. And I just want to thank you again and commend you on your great work that you've done in the presentation that you've shared with us today. It's greatly appreciated on behalf of AAAPC. So thank you. And just before we close this evening, I'll just like to remind we're doing a plug here to Dashini of the AAAPC 2024 Annual Research Conference, which is going to be held at Western Sydney University between the 15th and 16th of August. So I hope to see everyone there. And again, thank you so much, Tasha.
No worries, my pleasure.
Thank you for our audience for attending. Thank you.
Thank you.